Hi everyone, welcome to another Monty Hart lecture. It's a real honor to have a friend with us today, Dr. Juan Pablo Costabel from Argentina, who will be speaking about cardiac amyloidosis. It's a real pleasure to have him here today. Dr. Juan Pablo Costabel was born in Buenos Aires, Argentina. He earned his medical degree from the University of Buenos Aires and completed his cardiology training at the Instituto Cardiovascular de Buenos Aires. Throughout his career, he has led national registries in the field of coronary syndromes and cardiomyopathies, establishing himself as a key figure in cardiovascular research. Currently, he serves as a head of the coronary care unit and head of the research department at the ICVA, where he combines clinical practice with leadership in national and international clinical studies. His research focuses on coronary artery disease and cardiomyopathies, and today talking about cardiac amyloidosis. He is an associate editor of the Revista Argentina de Cardiología and the Latin American section editor at Progress in Cardiovascular Diseases. He has been a speaker at numerous congresses addressing cutting-edge topics such as biomarkers, coronary revascularization, cardiogenic shock management, and cardiomyopathies. It's a real pleasure to have you here today. Thank you so much for joining us.
It's my pleasure, Leandro, for inviting me here. So, regarding this topic, I think that most of us have learned a lot about this topic in the last maybe 10 years. The disease has changed, and trying to show some information about how it has changed. When most of us study cardiac amyloidosis, when in the medical school, we tend to use different terms to speak about the different kinds of cardiac amyloidosis that we have in the field and the different proteins, and it was really difficult to remember all those names. Today, I could say that it won't be a problem if we try to simplify the disease. Some folks may think that we oversimplify, but I think that we have so much information in cardiology field that if we simplify, it would be better. And I would say that in cardiac amyloidosis, it's okay if we simplify and say that most of the cardiomyopathy linked to amyloidosis that we're going to see in our practice are two kinds of cardiac amyloidosis. The cardiac amyloidosis linked to the deposition of light change that is overproduced because you have a plasma cell in the bone marrow that produce a lot of free light change, and if that free light chain deposit in different organs, we are going to talk about AL amyloidosis. And the other kind of amyloidosis that we're going to see is the amyloidosis that is produced by the deposit of TTR, the transthyretin, a protein that no one tends to know until we discover that it's linked to the disease. The disease that we tend to call senile amyloidosis. That is a term that we don't use anymore, and we say now that it's called TTR amyloidosis. That TTR amyloidosis may be produced because the protein is produced in a bad way, because we have a problem with DNA, and that we call that it's a mutation in the DNA. So that would be the hereditary form of cardiac amyloidosis, or the variant form of cardiac amyloidosis. But most of cases would be called wild type. And that's because the TTR tend to dissociate those monomers. Those monomers tend to produce amyloid fibrils, and that fibrils tend to deposit in the heart and in other organs. And we really don't know why does it happen. Everybody is trying to figure why it's happened. We know that it has a relationship with age, and it had a relationship with heart, and maybe there's a relationship between the something that happens in the heart when we get old, something related to sex, and the dissociation of the monomers that tend to deposit in the heart. So if we simplify, we tend to explain to our patient that if we think that there is cardiac amyloidosis, it might be related to AL or maybe related to TTR, and we have to perform a study to figure out which kind of amyloidosis patient is suffering from. The other explanation that we have understood in the last years is that amyloid, it depends on if the deposition is from AL or the deposition is TTR. There is two mechanisms why this amyloid is going to produce heart failure. The first one is related to the fact that it's going to deposit there, and it's going to cause stiffness in the heart and the going down relaxation mechanism. But there are another mechanisms that can affect the heart, and that's the cytotoxicity that produce the amyloid in the heart. And we tend to think that only light change produce cytotoxicity because it produces oxygen radicals. But we now know that TTR produces it too. And we know that AEL produce a level of toxicity that is much more higher than the level that produce TTR. That's why we now know that AEL evolved in a much faster way. And that's why we tend to say that AEL is an emergency in contrast to TTR that give us a little more time. But those mechanisms are very important because probably at the beginning of the process, the most important mechanisms tend to be the disruption of the relaxation. But at the end, or at the middle of the stage, the toxicity will be the main mechanism. And the important thing is that if we could remove the amyloid from the heart, but we are in the process that it has already produced toxicity, the myocyte is going to be altered, and it's going to be very difficult to go back if we want to turn the disease back. The third mechanism that we have learned is that the disease is a continuous. I mean, in the early phase, where we are just going to see nodular aggregates with ramifications surround and isolating the myocytes, and it's going to cause just a mild systolic dysfunction that probably it would be very difficult to see and very difficult to cause a clinical problem. And when the disease advances, there we're going to see wall thickness and convection abnormality and impaired ventricular compliance. And in the middle or late phase, we're going to see a restrictive physiology and atrial dilation. And at the end, we're going to see impaired systolic function. Why it is important? It is important because some years ago, we tend to suspect cardiac amyloidosis just when the patient has an abnormal systolic function, the atria were very big, the patient was in atrial fibrillation, and the systolic function was terribly affected. And now we know that this continues. So we can be able to, and we should be able to detect and diagnose the disease in an early stage. And the fourth mechanism that I think that we have understood is the fact that there's a big amount of TTR or AL that's going to deposit in the heart. But there's some of these fragment that's going to get out of the heart all of the time. The problem is that most of the time, the amount that is deposit is much bigger than the amount that leaves the heart. So the deposition goes up. So if we could stop the deposition in a very high way, maybe, and if we do it at the very early stage of the disease, maybe the spontaneous way that the AL or TTR goes away could make the heart goes back in the dysfunction that has already taken by the amyloid deposition. And an example of that is what happens in AL. In AL amyloidosis, when we use drugs to reduce the amount of bone cells that produce AL, we tend to see that the patients tend to get better if we start with those meds in the early stage. If we start on the late stage, nothing is going to change in the evolution. And that's why this explanation that Matthew Maurer introduced some years ago, I think it's really actual nowadays. I mean, there is a first stage when you're not going to see a reduction in ejection fraction, where you're just going to see that patient lose functional capacity, and there is a late stage in which we are going to see that everything goes down. So he tends to name that there is an ideal emerging therapeutic window, and I think that's very, very appropriate. I mean, we should try to detect, diagnose, and treat this patient in the early stage to change the natural evolution. Because if we diagnose those patients in the late stage, due to the fact that the amyloid is going to be very toxic to the myocyte, there is no way to come back from that phase. So when do we have to suspect this disease? And I think that we have learned a lot about the microvoltage and all that signs that we see in the ECG. But if you're going to wait for microvoltage or pseudoinfarction or atrial fibrillation or signs that might show the atrial enlargement, we are going to detect those patients in the advanced phase. So I think that the very way to detect those patients in the early phase is when you correlate your ECG with your echo. So you see in the echo that your septum thickness is enlarged, and it doesn't correlate with your ECG because your ECG doesn't show hypertrophy. There you have to think that something is happening, because there are much more diseases that are going to cause this absence of correlation. Most of the diseases that simulate cardiac amyloidosis, like aortic stenosis, hypertension, or hypertrophic cardiomyopathy, are going to show most of the time in the ECG signs of hypertrophy. So if you don't see signs of hypertrophy and you see that the patient seems to have hypertrophy, then something is happening. The patient doesn't suffer from pulmonary disease or something else that could alter the ECG. So you have to think that something is going to infiltrate your heart, and amyloid disease is the most common disease over 60-year-old. The echo might show you another signs that might help to suspect that the diastylic dysfunction, as we said before. You don't have to wait for those residual patterns because they are in the late phase. In the early phase, you're going to see, first of all, that the deformation is altered when you look for the tissue Doppler, and if you have the possibility of performing strain is going to be altered at the first time in the basal segments and the last time in the apical segment. So sometimes we see these beautiful figures in the strain. The MRI is a useful tool, of course, but sometimes we can confuse late gadolinium enhancement pattern with another cardiomyopathy. That's why it's not the first tool that we're going to suggest. We're going to suggest the ECG and the echo. And the other thing that it's very, very important is to look for other signs outside the heart, because these depositions are going to involve carpal tunnel syndrome, are going to involve gastrointestinal manifestations, are going to involve peripheral sensory motor neuropathy, autonomic neuropathy, ocular manifestations, and central nervous system manifestations. Of course, not all the forms of amyloid are going to affect in the same way these organs. TTR, the wild type form, is going to affect carpal tunnel syndrome or produce disease in your spinal cord. But when you have the variant form, those that we call it the hereditary forms, the neuropathy is much more important. And when we are talking about AL is much more a systemic disease that is going to affect gastrointestinal, skin, and other tissue. So we have to ask for these disease affectations so that we can suspect what kind of disease we are treating with. So I think that even though we have a lot of information about the echo, or as we said about MRI, we need to look at those ECG and try to find some information. As we said, because we don't have the right concordance between the ECG and the echo patterns. So that's maybe the very big red flag. We made a recent publication. It's going to be published soon, and we're trying to find different patterns of left ventricular hypertrophy in TTR cardiomyopathy, and we compare with hypertrophic cardiomyopathy, hypertensive cardiomyopathy, aortic stenosis disease, and then you can see that there are some patterns that are not even shown in TTR, like Sokolov. So when you see, it's a small number, but when you see a patient with hypertrophy in the echo, you don't see Sokolov. We tend to think it's reasonable to tend to think that PTR might be a possibility. When you look at the different other patterns, maybe the other patterns are not so specific or sensible as we tend to thought before doing this trial. And of course, artificial intelligence is going to facilitate all these. And there are a lot of people that is working on these. We're working in a simple way, or trying to figure out which kind of ECG are part of amyloid, or which kind of ECG are part of other kind of myopathy, starting with people that have a septal thickness over 12 millimeters and are over 60-year-old. So it's easy for the AI to find patterns there and to say, for example, I put the ECG and said it's not cardiac amyloidosis, it looks like hypertrophy cardiomyopathy. So, which is the real prevalence of this disease? When we look at the anatomical features, maybe we tend to overestimate the prevalence of the disease. For example, in this study, they tend to find that 1 in 4 patients over 80-year-old had in their heart enough amyloid to think that they could have suffered from cardiac amyloidosis. We know that having amyloid in your autopsy doesn't really mean that you suffer from cardiac amyloidosis, but it tends to show that maybe it's a normal process of elderly to find amyloid there. If we try to find patients before that, we have information from patients that suffer from aortic stenosis that are undergo a transcatheter aortic valve replacement TAVR, and we find that over 75-year-olds, 16% of patients, of male patients over that have aortic stenosis may suffer from cardiac amyloidosis, most of them from TTR. In females, the rate is much lower, as you can see. Some years ago, Pablo Garcia Pavia and the group from Spain performed this work in their inpatient, trying to find which of them that suffer from heart failure with preserved ejection fraction could have cardiac amyloidosis. They exclude those patients that had different disease. For example, those patients with coronary artery disease, those patients that have pacemaker, valve disease, and they found that 13% of patients that were admitted for heart failure with preserved ejection fraction and a wall thickness over 12 millimeters suffer from amyloid. And 1 year ago, Ana Spacamento, that's a fellow that works with us, performed the same study in our population, the same study, but the difference at this time that was that she didn't exclude those patients with coronary artery disease or valve disease or pacemaker, and she found the same amount of patients that suffer from cardiac amyloidosis. And I think that what can we learn about this? We have to learn that something that is obvious is that patients with cardiac amyloidosis may suffer from coronary artery disease, may suffer from valve disease, may suffer from hypertension, and that's not a reason why we have to exclude that those patients suffer from cardiac amyloidosis. So we have to look for cardiac amyloidosis in patients with heart failure with preserved ejection fraction, because probably 1 in 10 are going to suffer from cardiac amyloidosis. And we are going to discuss that treatment is probably completely different. Prognosis is different. Family evaluation is completely different. So it's worldwide to look for that. If we tend to think that 1 in 10 patients with heart failure with preserved ejection fraction suffering from cardiac amyloidosis. I made a calculation to try to figure out how many patients in Argentina, for example, should suffer from cardiac amyloidosis. And we know that Argentina has 40 million of people living with us. We know that the 2% of them suffering from heart failure, so it's 800 thousand people that suffer from heart failure. We know that 1% suffer from heart failure with ejection fraction. That's numbers that are globally. So there you have 400,000 people. So if we think that 1 in 10 suffer from cardiac amyloidosis, we should find in Argentina 40,000 people that should have cardiac amyloidosis. And those are not the numbers that are actually diagnosed from cardiac amyloidosis in Argentina. So we think that the numbers that are not diagnosed are really, really very high. The other situation is it's important to diagnose these patients earlier. Well, we tend to, if we look at the numbers that have been diagnosed in the latest year, we see that the numbers of patients that have been diagnosed from cardiac amyloidosis has grown up, really grown up. And if we look at the stage, I mean, how are they affected from cardiac amyloidosis? How high are their troponins, their BNP, and their heart failure? We tend to appreciate that nowadays patients are diagnosing when they are not so sicker. It tends to happen in the latest year, and I think the explanation for this is that we understand that the disease can be diagnosed earlier, and we know how to look for the diagnosis early. But the other thing is really natural is that when diagnosed patient earlier, their certain thickness is lower than before, the ejection fraction is higher than before. And when we look at the evolution of those patients, we see that patients that are diagnosed earlier have better evolution than patients that are diagnosed late. And sometimes we tend to think that, okay, if we diagnose patient that in the later phase, the evolution is different just because we are diagnosing them in the later phase, but we are not changing the evolution. And nowadays we have enough information to think that the treatment that we can provide to this patient can change the evolution. And diagnosing this patient earlier in their phase can really change the curve of evolution. So how we're going to diagnose this disease? First of all, we have to suspect the disease. And when we have enough suspicion, we have to order for light change, pre-light change in blood, in serum. So what's the explanation for this? As we said, we have a monoclonal cell that's going to produce a monoclonal gammopathy. That monoclonal gammopathy is going to produce a higher rate of kappa or lambda. So ratio between kappa or lambda, that the only light change that we can have in our body and that we can measure in our body is going to be abnormal. So it's easy nowadays to measure light-free change. It's enough to ask for a proteinogram or ask for immunizations. No, it's not enough. As we can see in the graph, the proteinogram is not enough. It's enough to see and to detect a very big amount of gamma chain, but no small light-free chain. And why is this important? Because most of the patients that suffer from AL, cardiac amyloidosis, are not going to have multiple myeloma. They're going to have something similar to MGAF. So if we look to their proteinogram, it's going to be normal. So we can exclude the disease just with the protein. And we can exclude just with the immunization that is normal. So why we ask for immunization? We ask for immunization because we had higher level of light-free change, and we have immunization, the chance of having malignant disease is higher, but not to exclude. To exclude is enough to have normal light-free change. We have to know that light-free change are eliminated from the body, most of them from renal. So if we have a disease that affect our kidney disease, then we are going to have a problem to eliminate predominantly kappa light chain. So we are going to look to the filtration rate. I'm going to see the filtration rate is normal. We're going to admit a normal free light chain ratio, as the image says, between 0.26 to 1.65. But if you have a normal globular filtration rate, that's something that is very common in elderly people, we are going to admit higher free line change ratio for kappa, not for lambda, because kappa is affected by kidney disease and lambda is not affected for kidney disease. That's an important message. We only accept alter ratio when you have abnormal kappa light change, but not lambda light change. And then we have this great discovery. We really don't know how does it work, but scintigraphy, when you use bone marrow tracers, tend to uptake in those patients with TTR. Most of patients with TTR tend to uptake in the heart. So now we know that the grade of uptake in the heart is related to the chance of having TTR in your heart. But and that's the good information. There are some false positive for scintigraphy, and there are some false negative for scintigraphy, and that's something that we have to know to deal with this disease and avoid making false or mistake in the diagnosis of these people. That's why Gilmore et al. Published this paper in 2015 and showed that the combination of measuring life-free change and performance scintigraphy is good enough to diagnose most of the patients with cardiac amyloidosis. So now we know that when you have life-free change that is normal, ratio normal, and the numbers are normal, and your scintigraphy is positive, you have the chance of over 98% of having TTR. So we're going to ask for a genetic test to know if we are talking about the hereditary disease or a wild type disease. And in the other side, when you suspect cardiac amyloidosis and life-free change are high and scintigraphy is low, then you must suspect that you have an AL amyloidosis. But everything starts when you suspect the disease. And that's why it's very important that we know when to suspect the disease. So when we suspect the disease, we start the diagnosis algorithm. Fortunately, most of the patients are going to be in the extreme of this algorithm. I mean, life-free change that are going to be normal, and scintigraphy that's going to be the high uptake, and the other way, life-free change that are going to be abnormal, and scintigraphy that's going to be normal, but we have to suspect AL. There is a few patients that we are going to make a different workout to find out if they are amyloid or not. But fortunately, there are just a few patients that are going to make a difference. And at the end, which is the treatment for these patients? And I think that the key message of this talk should be that we have to think in a systemic disease. And when we think in a systemic disease, we are not going to just treat the heart. Of course, we're going to treat a specific treatment to the underlying disease. I mean, if the problem is that you have TTR deposit in your heart or in your kidney, you have to slow TTR deposition. If you have AL deposition, you have to slow AL deposition. You're going to treat the symptoms regarding to the heart failure. And now we know that heart failure should be treated in a different way when we are talking about amyloid patient and we are talking other etiologies of this disease. We're going to treat cardiac arrhythmias in a different way. And we're going to treat this patient with valvular heart disease in a different way too. But it's very important that we work in team to treat those extra cardiac involvement that are going to affect prognosis and going to affect quality of life of this patient. So now, fortunately, we have developed different treatment to reduce TTR deposition. So we have some treatment to avoid the production of TTR. Some years ago, the only thing that we had to we could do for this was liver transplant. Now is something that we rarely do. So we can stop the gene, and that we are working on some technology regarding CRISPR technology to avoid TTR production, to knock out those genes. And there's a trial called Magnitude that is enrolling patients at this day, trying to figure out if this treatment could be good for our patients. We have one point after that, we can silencers of the ARN, like patisiran, vutrisiran, and eplontersen. We have already some information about patisiran, vutrisiran, and we're waiting for the information about eplontersen. We have stabilizers. The stabilizers are the first kind of drug have been studied. And now we know that tafamidis is a good drug that really can stabilize, and stabilizations tend to change the evolution of those patients. Acoramidis is a drug very similar to tafamidis and that have shown similar results. And we are waiting for some information about the way that we can deplete the amount of TTR that is already in the heart. We had a very very promising information about doxycycline and ácido tauroursotoxicólico that could help, but the information is not enough to treat our patient. And there are some ongoing trials regarding antibodies for amyloid, and we are going to see the result in a few years. But the first information that we had was regarding tafamidis. Tafamidis is a molecule, as you know, that stabilizes. And I think that the important thing about this is that stabilizing the TTR can change the evolution of the disease. And we saw in this first population that was a very sick population, that stabilizing tend to change the mortality rate of these patients, tend to change the hospitalization of these patients, tend to change the heart failure, the arrhythmias in these patients, tend to improve quality of life of these patients. And we understood that we need some time to change mortality curves, but the effect on quality of life comes sooner, and that's a good information for our patient that sometimes privilege the quality of life over mortality. And we knew that when we treat different stages of these patients, the effect of stabilizing was different. As you can see here, when we treat patient in functional class 1 or 2 or 3, the effect of the treatment was completely different. And we know when we started the extension of the trial, that when we start treating those patients that were at first in placebo, the curves change, but never reach the curve of the patient that started taking tafamidis. So now we know that if you're going to stabilize, if you're going to treat this patient, it's better to do it sooner and not waiting for this patient to get worse. As we said, acoramidis is a result that show that stabilization is a good result. Something that happened with dapagliflozin and empagliflozin, and we saw that the results were similar. It's a good news to have the similar result. Treating patients with this stabilizer that is very similar to tafamidis, that's called acoramidis, tends to have the similar result. And what about gene suppression using vutrisiran? Gene suppression using vutrisiran have good results too. The study was positive, the use of vutrisiran in this patient, even though in patients that were on treatment with tafamidis, as we're going to see, reduce the cardiovascular events and all-cause mortality. That was the endpoint. And it was very interesting that the effects tend to occur in patients with monotherapy, I mean patients that weren't taking tafamidis, and it happened also in patients that were on tafamidis. So we tend to think that silencers results are similar to stabilizer results, but we hypothesize, right, that if we could add silencers to stabilizers, we could get better results. Either of if we treat patients that don't respond appropriately to stabilizers, they could get silencers. But that information has to be proven in next years. Fortunately, what we get from these trials is when you see the population that was treated in the family's trial, acoramidis trial, and vutrisiran trial, you see that patients are different. Patients are in early stage, and the mortality of the control group is different, and the mortality of the on treatment group is different. So it means that evolution of the disease is changing. When we see real life patients treated with tafamidis that are selected patients that receive, for different reasons, tafamidis that are compared with those patients that unfortunately or for another reason are not treated with tafamidis, you tend to see that tafamidis patients get better results. And nowadays we can think that the mortality has really slowed down comparing to what happened in the past. So this figure that Matthew Murray published some years ago, I think is more useful than ever. We have to diagnose patients earlier, treat patients earlier. We have some questions that have not been answered yet, and we can discuss later. The other thing is that treating patients in a holistic way. I mean, not only treating the deposition of the amyloid that is provoking the disease, but also the heart failure that is already suffering the patients, the thrombotic risk, the arrhythmias risk, the valve disease, and the extra cardiac disease that the patient can suffer, and that teamwork is the best way. So my final message, I would say that the diagnosis of cardiac amyloidosis has been simplified, allowing us to easily rule out or rule in the condition. And as we have experience from other disease, I think that it's very important to rule out as soon as possible that the patient is suffering from cardiac amyloidosis, because making the diagnosis later change the result. Improvements in the treatment of patients with cardiac amyloidosis, especially TTR, have impact both in life expectancy and quality of life. The benefit of anti-TTR treatment should be initiated as early as possible. The treatment approach must be comprehensive and multidisciplinary to get the better result. Thank you very much, Len.
Thank you so much, Juan Pablo. That was amazing. I really like the high-end overview, so we can understand a little bit better all these difficult clinical situations. So please, everyone, put your questions in the Q&A, and then we'll go through them. So I think the problem that you're mentioning about underdiagnosing is not only there, here is huge as well. And when we do those calculations here, we're extremely underdiagnosing these patients as well. I saw there that you're flagging the ECGs. Is that a method or that you're doing to flag as potential cardiomyopathies? Are you applying that already?
Yes, we're working with that, and we're working with AI to try to facilitate that information. Sometimes when you have some experience and you don't need to be an expert in the field, and you just look at the ECG and you say it's not an hypertrophic cardiomyopathy, you don't need much more than that. But I think that due to the ability of other imaging technique, the time that we spend looking at the ECG has slowed down, and we tend to miss that information.
No, that's very important. But I think sometimes even we may not need an AI just to flag them and have someone pick up all those
Yes.
bases to be seen. But very, very important. So we have a comment from Ahmed, one of our research fellows. He says, we're in the way of depending on focusing on personalized medicine with the advancements of genetic testing. He's asked if there's any standardized or specific diagnostic criteria with biomarkers or imaging that you're aware that is coming sooner or there's under the works.
No, I would say that there's no biomarker that is going to be available to say just because of the biomarker. We know that this patient higher level of troponin, higher level of BMP, but there's not a number to say that with that number you have to think in cardiac amyloidosis. So not yet. And the other question is, when we treat this patient and we need to know is the disease is how is going on. I mean, it's getting worse, not getting worse. The treatment that we are giving is enough. Not, we need to change to another therapy. I think that that's the next step.
Thank you very much. We have a question here from Dr. Bradlow. He says, should we be testing patients before TAVR? Tell me what you think, then I'll tell you what I think. We're using CT for some of these here, but what are your thoughts?
I really think that we should test all patients with preserved ejection fraction with heart failure. You should test all of them over 60-year-old, and you should test all your patients with TAVR. And sometimes someone may argue that why are we going to test them if we are going to perform TAVR anyway? And yes, I know most of the time we're going to perform TAVR anyway, but the way we're going to treat that patients, the treatment that we're going to offer those patients, the treatment that we're going to offer the family of those patients in case they are hereditary form, are going to change.
Yes, 100% I agree. So it's not that you're going to decide not to do the TAVR, but you need to know what the patient has. That information is power and deciding, even for heart failure, right? How to use or not use beta blockers, or now with all these targeted therapy. So here with CT, what we're doing is we're using the protocol for ECV calculation with CT. And in that way, you can flag some of these patients that may need further testing for amyloid. But
That sounds great.
Yeah, I think we're not using it fully clinically yet, mostly for research, but I think very soon will be deployed clinically. We have another question. The speckle tracking showed promised results. However, there are some concerns regarding sensitivity and specificity of the test. Do you think any AI will be able to enhance this test further?
Yes, I think that AI and technology is going to improve the result of the speckle tracking. But I think that speckle tracking might be useful to diagnose those patients earlier. I mean, if we perform speckle tracking to all the patients that have hypertrophy, are going to find, maybe we can decide who to test or who doesn't to test. But it's not really at this moment ready for do that. It's a complementary tool nowadays.
Yeah, I agree. I think I really like your concept of moving this to early diagnosis. The problem with imaging is that many of the things we do have the typical findings later to later stages. So we really need to change the way we think about disease and research these patients and image them early so we learn more and create criteria for that. The same with MRI. Once you are a full-blown amyloid that you show there, then it's not that
Yes.
useful.
Yes.
Yeah, we have a lot of issues with quality as well, answering here to Ahmed. Sometimes if you have bad quality echoes, then and it's not tracked very well with the speckle tracking, it's not going to work.
That's right.
Yeah, so thank you very much. I think we don't have any more questions. Let me see here in the Q&A. We have one from Daniel Lorenzati. It says, thank you for the update. Mariana Fontana has shown the potential of CMR-derived extracellular volume for monitoring treatment response. Do you think we are there yet?
I think that we can in some time go that way. It sounds promising, but I think that the way that we should go maybe with some kind of biomarker of measuring TTR to see if we are doing the treatment and doing the shock that the patient needs. Maybe the combination of some biomarkers or measurements of TTR with a precise image quality can tell us if the treatment that we are providing to the patient is enough or we have to move to another therapy.
I agree too. I think you need, if you're going to be changing your management based on such a specific marker, you need to be really sure that that's accurate, and you need to be sure that you can
Yes.
rely on it. And I think when you expand this to, from one institution in the world that specializes into that to all countries, all institutions, you can run into trouble as well. Okay, so thank you very much. I think this was outstanding. I enjoyed it a lot. Hopefully you enjoy the weekend in Madrid. And
yes, I hope
we'll see
to.
you in New York.
Yeah, thank you very much for this invitation, Leandro.
Okay, so I'll see you soon.
See you soon. Bye bye.